Okay. Hello, everyone. Good afternoon. Welcome to the IARS Virtual Education Webinar, Scaling Outpatient Joint Arthroplasty Across an Integrated Health System, Clinical Innovation and Implementation Lessons. This webinar has received no commercial support. And this is a reminder to register for the 2026 annual meeting in Montreal, Canada. Early registration rates deadline is March 12th. And if you missed the 2025 annual meeting, on-demand recordings are available for purchase. For more information, visit the link on the screen. And this is a slide on upcoming webinars. You can visit iars.org/CME webinars to register. And to submit questions via the Q&A button below. We'll get to that at the end of the talks. So as an introduction, my name is Ed Yap. I am a practicing anesthesiologist and senior physician with the Permanente Medical Group. I'm a physician researcher and adjunct investigator at Kaiser Permanente Division of Research, and I help the anesthesia specialty research within our organization. My research focuses on the impact of regional anesthesia and acute pain management on surgical outcomes. And I also conduct health services and population health research with a focus on how technologies such as machine learning and AI can be used to improve perioperative care and patient outcomes. My colleague, Dr. Brad Cohn, is an anesthesiologist and critical care physician practicing at Kaiser Permanente, Northern California. He is a champion for perioperative medicine and has a passion for health system design and has the privilege of working in an integrated healthcare system responsible for the well-being of approximately 5 million patients. As both chair of perioperative medicine and regional medical director for operating room operations within his organization, it's his goal to provide timely access to surgical care for our entire population. Next would be Dr. Mark Thoma, who is a board-certified anesthesiologist and senior clinical executive with more than 15 years of leadership experience in anesthesiology, hospital operations, and healthcare technology and strategy. He serves as the chair of anesthesia at the Permanente Medical Group, the largest integrated medical group in the United States. Dr. Thoma has led large-scale change initiatives across complex systems, advancing emergency preparedness, physician recruitment and retention, and strategic service line growth. Recognized for cross-disciplinary leadership and physician mentorship, he also contributed nationally to the development of anesthesiology standards and policy. Last, Dr. Jennifer Nornberg has been in practice for over a decade, with most of her time in Southern California Permanente Medical Group in San Diego. She originally trained in regional anesthesia and perioperative pain and recently completed her fellowship in integrative medicine and is now taking those combined skills to advance perioperative optimization and risk stratification through the education of all stakeholders, optimization of workflows, and continuing to provide patient care. So for today's session objectives, these are it. We hope to describe the anesthesia approaches in supporting evidence for outpatient total joint arthroplasty. We're going to discuss the role of perioperative risk stratification and optimization in supporting same-day discharge. We'll identify key operational strategies that enable large-scale implementation across our health system and compare approaches and adaptations made across different regions within our integrated healthcare system. So this is my disclosure slide. Again, I'm Ed Yap. I'll be presenting today on translating research into practice. So my hope for this brief talk is to compare neuroaxial and general anesthesia for outpatient total joint arthroplasty, the impact on early postoperative outcomes and discharge readiness, describe some of the evidence behind multimodal analgesia regimens for this population, and the effect on pain control and opioid utilization, and then evaluate regional anesthesia techniques and the outcomes in total joint arthroplasty. So total joint arthroplasty length of stay has decreased since the early 90s through the 2000s, as shown by this observational study graph here. What used to be on average 1 week to 10 days, now we're sending patients home the same day. quite amazing. What these two charts show here, the one on the left is for knee arthroplasty and the one on the right is for hip arthroplasty, are national registries of inpatient surgery in orange and ambulatory surgery in green. And as shown, there was around a change in 2018 and moving forward where outpatient total joints kind of slowly crept up. The drive towards this new paradigm for reduced hospital time is multifactorial and really driven by the creation of bundle payments and the removal of total hip and knee arthroplasty from the Medicare inpatient only procedure list in 2018. And then the increase in demand for these surgeries have created an economic incentive for decreasing hospital length of stay after surgery. Interesting, the COVID pandemic in 2020 really accelerated the adoption of outpatient total joints, especially in the hip arthroplasty population. This is a graph showing our institutional rollout of total joint home recovery. And those same-day discharge rates we're showing here from 2017 to and beyond. We see this similar patterns from 2017 and stabilizing, plateauing around 2020 of greater than 80%. In rolling out this program, we created a institutional playbook. It was a multidisciplinary care team, and part of us as anesthesiologists are one of the key players, part of this whole care pathway. What we do is very important, and the role that we serve and the way we can change our practice can impact the way we have success. So in thinking about what we can do in our practice, we thought, well, does the type of anesthesia we provide matter? The practice across hospitals really derived from an important prior studies like the one by Memsudis and team that examined a large population of over 380,000 patients undergoing hip and knee replacements. What they found that the utilization of neuroaxial compared to general anesthesia for primary joint arthroplasty was associated with superior perioperative outcomes, with neuroaxial associated with decreased morbidity and mortality. So we thought in our patient population, for patients who are selected for outpatient total joints, do these results really stay consistent? Because we're choosing patients who may be a little healthier to start with, does that neuroaxial anesthesia confer benefits? So in 2020, we hypothesized that patients receiving neuroaxial reduces the incidence of adverse postoperative outcomes compared to general anesthesia, and this was published in 2022. A goal for this study, our primary endpoint was to look at 30-day postoperative major complications, which included a composite incidence of mortality, myocardial infarction, DVT, PE, stroke, and acute renal failure. So I'll just describe our study methods here. We looked at 21 hospitals across Northern California from 2017 to 2019. Our total cohort that we found was about over 14,000 patients, and after exclusion went down to about 11,500. And then between the two cohorts, we compared the general anesthesia group and the neuroaxial group here. I'm jumping to the results here. What I'm showing here is a forest plot of our outcomes. And as you can see, major perioperative complications occurred in similarly low rates in patients receiving neuroaxial anesthesia compared to patients with general anesthesia, with really no statistically meaningful differences between the two groups. So anesthesia type was not really associated with an increased risk of major perioperative complications. However, what was interesting in our secondary findings is that we found that neuroaxial anesthesia was associated with lower postoperative pain scores and decreased perioperative opioid use. It was associated with lower incidence of PONV, associated with less blood loss and PRBC transfusions. And really important, neuroaxial was associated with a higher rate of successful same-day discharge with about a 29% improvement rate. So jumping over to multimodal analgesia, the concept of multimodal is combining oral analgesics of different classes and with different modes of action has been shown to yield additive pain relief. This is an effective way of limiting the use of opioids perioperatively and thereby avoiding their well-known side effects. And I can't go over all the different types of non-opioid analgesics, but I hope to highlight 3 different classes. And then I present information and a takeaway point from a lot of the meta-analysis and systematic reviews that we review here. So the first medication I like to present on is ketamine. It's a commonly used NMDA antagonist. It's shown to be safe and demonstrates improved pain and decreased opioid use after hip and knee arthroplasty, as seen by multiple reviews and meta-analysis. Pain reduction at rest and at movement has decreased for about 5 to 10% when you look at these studies. Ketamine also reduces the morphine consumption, roughly 8 milligrams every 24 hours after use. The safety profile is really safe. CNS adverse events occurred in about 5% of ketamine patients versus 4% in controls, with no significant increases in sedation, dizziness, hallucinations, and delirium. But it should be used cautiously in patients at risk for postoperative delirium, such as the elderly. Next, we examine corticosteroids, specifically dexamethasone. When we examine multiple studies, we find that there's improved outcomes in patients who receive perioperative dexamethasone to reduce pain, opioid consumption, PONV, and length of stay. Pain score reductions at rest and dynamic movement. A lot of meta-analysis shows single dose of dexamethasone can reduce a pain score at rest by approximately 0.71 points over 24 hours. The last multimodal analgesic medication I'd like to review is gabapentinoids. Some studies and meta-analyses suggest gabapentinoids may reduce postoperative opioid consumption. However, there are many studies that show no significant differences in pain alleviation or opioid consumption. The American Academy of Orthopedic Surgeons Working Group concluded that the use for acute pain carries risk of sedation and dizziness, concerning for patients at risk of side effects. Perioperative gabapentin was associated also with significant increase of in-hospital delirium and pneumonia. Lastly, shifting over to regional anesthesia, and the goal of the goal of regional anesthesia is preserving early mobilization and aligning with your institutional practice resources and skills. And the overall consensus is peripheral nerve block use is recommended for patients undergoing total hip and knee arthroplasty, except when contraindicated. I like to highlight the study with Mensodus and the IARS group, a consensus group of international experts that showed that analyzed 122 studies, which revealed that peripheral nerve block was associated with lower odds of numerous complications, including cognitive dysfunction, respiratory failure, cardiac complications, surgical site infections, thromboembolisms, and blood transfusions. So key summary and recommendations from this talk is that multidisciplinary coordination is needed for a successful outpatient total joint program. Anesthesia technique matters. Neuroaxial is associated with improved discharge readiness outcomes. Multimodal improves care. Consider corticosteroids and ketamine in your analgesic protocol, but be cautious with gabapentinoids. And regional anesthesia plays an important role in early mobilization and recovery. Thank you. I will be moving on to Dr. Brad Cohn, and I'll be pulling up his slides.
Thank you, Ed. While you make that transition, I would like to thank all of you for being here to understand the choices that you make and how they matter for the care of orthopedic surgery total joint patients. Dr. Yap just persuaded me that the choices we make about the mode of anesthesia and our multimodal analgesic approach matter to the outcome of whether or not the patients are able to be discharged to home. I'm going to try to persuade you in the next 10 to 15 minutes that the choices we make about caring for our population of perioperative patients matter tremendously in terms of the outcome of whether or not they successfully proceed to surgery and in terms of the outcomes they have with their surgery. And I'll be explaining to you how we approach preparations for our patients for surgery in Kaiser Permanente, Northern California. Next slide, Ed. When we talk about population health, we talk about 4 key approaches to assessing our population to understand their fitness for surgery and to prepare them as individuals to have the most successful possible outcome. And we use the approaches of access to perioperative medicine, triage into the right mode, length, and type of appointment, the wise choices around perioperative testing, and the key focus of preoperative optimization as the ways in which we can influence this decision. And over the next few minutes, I'll walk you through how we approach breaking down this pyramid and starting with the foundation of access first. Next slide. When we talk about access to perioperative medicine, we're actually asking ourselves whether or not we've identified the right cohort of patients, perhaps in the same way that you as researchers might approach evaluating whether or not you've identified the right cohort to study. In the next slide, I'll tell you how we approach understanding whether or not we've identified the right patients to be cared for through our perioperative medicine system. The first question we ask ourselves, and apologies, please advance to the next slide. The first question we ask ourselves is the procedure that we're considering associated with a range of outcomes, favorable and unfavorable, that we might influence? Second, are these variable outcomes associated with the patient's medical comorbidities or their underlying burden of disease? And would the typical patient benefit from any techniques around optimizing their health, reducing their risk of harm, or pursuing a greater wellness as they approach surgery? And can we offer an individual patient or a segment of our population better support around personalized risk assessment that might influence their choice to proceed? If any of these questions are yes, we think we've identified the right patient for perioperative medicine. And several of these questions fall into a yes category when we think about the cohort of patients that typically undergo total joint surgery and the procedures themselves. Next slide. Next, we focus on triage. Not every patient in this cohort that would benefit from perioperative medicine needs the same type of care. And when we think about what that means, we think about our whole population of patients, several 100,000 patients per year over many years, and we think about whether or not our surgeons think about them as having uniform or different risks. And in the next slide, I can share with you our thinking about how patients were previously triaged into perioperative medicine clinic visits of different length, type, and modality. Next slide. When we looked back at our population of patients that we served, we recognized that there was not a uniform distribution of perceived risk among the patients receiving care at our 16 different hospitals in Northern California. Instead, we saw tremendous variability. And where we saw variability, we interpreted that to mean there was greater opportunity to standardize the way in which we triage patient risk across our population. Because while there perhaps are some geographic differences in terms of the frequency of risk that we would encounter from geographic location to another, it should not be this great. There's more heterogeneity than we would expect. And we approach this in many different ways over time. In the next slide, you can see that we approached this initially by trying to create lists of various medical comorbidities that were associated with a greater risk of harm. We tried using education on the part of our surgeons to try to create greater knowledge about what a high, moderate, or low risk patient might look like. And we certainly relied on trials that used the established ASA physical status risk score to try to identify patients who were the highest risk. But in each of these endeavors, we found greater heterogeneity and poor inter-observer reliability when we tried to risk stratify our population using these tools. So we moved towards a more objective and automated approach to risk stratification. We moved towards something that we call the comorbidity assessment for surgical triage tool, which we have shortened to CAST. And this is an approach that may mirror the approach that you might be familiar with in other large health systems or perhaps commercially available tools. The concept is identify those predictive variables that you can know with certainty about your population, perhaps their age, scalars for comorbidity burden, lab abnormalities, or the choice in terms of the location for that procedure to occur, and then compare those to the known outcomes that are of significance. To us, it was the clinical outcomes shown here, which are part of the National Surgical Quality Improvement Project's outcomes of significance for us in the United States. What we were able to create with this model is a segmentation of our perioperative population into low, moderate, and high-risk populations. Those where we had known likelihoods of these adverse outcomes that increase as the risk category goes up. We also recognize that to provide patients high-quality preoperative care, you need to know more than the risk of harm. You need to account for the complexity of providing care in the preoperative visit. And in the next slide, the way that we approach this was to try to understand, in addition to the risk of of adverse surgical outcomes, what would be the time necessary to provide the excellent care that we believe these patients deserve, both during a clinic visit and in the time leading up to the visit where our clinicians prepare, and in the time subsequent to the visit where our clinicians follow up with both conversation and diagnostic tests that have been ordered during that encounter. And we were able to quantify this investment of time using a second modeling technique. And in the next slide, you will see how we built the time in the electronic health record model, or timer, which looked at how associated patients' medical comorbidities, medications, or other factors were with an increased amount of time being committed to their care, looking at historic patient visits, several 100,000 patient visits over a significant amount of time. And using this overlap of patient risk and visit complexity, we were able to create a care delivery system that was aware of both factors with respect to our patients in an automated fashion. And in the next slide, you can see how we presently approach the distribution of patients to different visit lengths, modalities, and even provider type when thinking about whether the care is provided by a physician or an advanced practice provider in our system of multiple different hospitals spread across Northern California. But just getting to the right visit for the right amount of time doesn't influence outcomes alone. You need to be thoughtful about what you test for and how that relates to what you can do for these patients to confer some benefit. And so we have developed, like many of you, some thoughtful approaches to which tests should be ordered based on patient comorbidities over which time frame, and try to make this as easy as possible for our system to follow as time moves forward. What you see here is our guidance, and I suspect that regardless of where you practice, there is a paper pinned to a wall with an antiquated version of this same concept, where you associate comorbidities with specific tests on a typical timeline so that you can influence the rational allocation of tests, both from a resource stewardship perspective and to make sure that important clinical information isn't omitted in the pre-op timeline. And this is beneficial, but this is insufficient to guide practice. And so what we have found to be tremendously valuable is to integrate this knowledge automatically into our electronic health records system. And the way we presently practice is by having logic that puts forward the recommended tests to the surgeon at the time of case creation, which can be tracked and followed by all members of the perioperative team, whether those are members of the perioperative medicine care team or the anesthesia care team, so that we know what would be recommended for the patient, which tests have been completed, which tests haven't been completed, and whether or not those tests revealed any abnormalities which we should pursue. And finally, what matters to the patient is how you can reduce the risk of harm. And so we think very critically about optimization, but we think about it not just as something that happens during a 20, 40, or 60-minute care visit. We think about this as something that we can do for the population at any point after their case is created through the day of their surgery. And the way we focus on this can be shown in the next slide. What we studied were all of the predictors associated with harm and the outcome of surgical case cancellation on the day of surgery and in the 7 days leading up to surgery that we might influence. And we worked to organize our thinking as an enterprise so that all of our anesthesia clinicians, all of our perioperative medicine clinicians, and all of our surgeons across specialties had reached consensus around what optimization looked like, what specific targets with respect to, for example, BMI, blood pressure, tobacco status, endocrinopathies, etc., would qualify a patient as being optimized for surgery. Where would we find some concerns among our clinicians? And where would red flags be raised to say, this is a patient for whom we can make a difference in terms of their outcome, or who may not proceed if they appear for the day of surgery with this particular factor in this state of disarray? And beyond thinking about establishing our clinical targets, what we did is we created a population health tool, one that would show us at any given moment where each of our individual patients rests with respect to these clinical conditions, so that we could know if there were patients whom we could provide some targeted outreach to help move them from, for example, a red condition to a yellow or green condition, or if we found ourselves operationally with an additional operating room, additional hours to provide care, so we could identify from our large population those patients who are both most logistically and clinically ready to receive our care. And this made a tremendous difference in how we stratified our population. But everyone wants to know, what measurable outcomes did this system achieve? And I think perhaps the most uniform and universal outcome that people look to for a successful perioperative medicine system is, how successful were you in bringing your patients safely to the OR? And what you can see here are our actual 0 to 7 day surgical cancellation rates over time. And something that I think we all share a lot of pride in is that our 0 to 7 day cancellation rate for inpatient and outpatient orthopedic surgery in our organization are the lowest now that they've ever been. And we attribute a lot of that success to the system I just described. Thank you for your attention. And I'd love to pass the conversation to my friend and colleague, Dr. Mark Thoma, to take us through the next section.
Thank you, Dr. Cohn. So what is Dr. Yap's pulling up my slides. What I'm going to talk about is how you take a process like this, where you've identified a great workflow everywhere from the pre-op to inter to post-op period, and how do you scale it from a single location, that you've tried and tested and tried, and scale it across a large enterprise. Next slide. So the keys that you're doing is, the biggest challenge probably is that no two sites across your system are going to be the same. Your patient populations are going to be different. There's going to be different cultures, different workflows, your different resource levels, despite being in the same institution, in part because of different sized hospitals. You're going to have different local priorities. As much as you're coming down from a systems level, there may be other interests that are going on at the local sites. Your pilot may work well, but maybe it doesn't work well in every situation. And then also that idea of standardization versus local adaptation. Are you imposing and pushing down from the top, or are you giving a little bit of range to the local sites to implement, as long as you're keeping the theme the same? Next slide, please. So this roughly is a map of the Kaiser Permanente service area across Northern California. We serve close to 5 million members, over 21 hospitals and ASCs. The service area encompasses 28,000 square miles, which includes parts or all of 20 counties in Northern California. So roughly, we're spreading this out over the size of South Carolina. We have big hospitals, we have little hospitals, urban, suburban, rural, and we're also looking at about 425 career track, partner track anesthesiologists, 400 career track CRNAs, and maybe 100 pools per diems. So there's going to be some variation. Next slide. So you want to make sure that you have a good governance and an accountability structure. Obviously, an executive sponsor who is going to be leading this program. Our system is set up where we're organized both along service lines, so anesthesiology, arthroplasty, medicine, et cetera. And then we also have a local structure where we have a physician in chief, much like a CEO, associate physicians in chief, et cetera, down to the service levels. So the local leaders have to be accountable to their regional partners. You have to have clinical and operational leads established at all of those sites. I can't emphasize enough the importance of site champions. You're strong, eager, want to make this work type people who are going to do this. Having central project management, so as all of these different sites are starting to begin and fill out their work, that they're reporting back to sort of a central agency to talk about how their progress is going. And defining well your decision rights and your escalation pathways. Is something working? Is something not working? What can we change on the local level? And what can we not do? Having that pilot team of high performers will help ensure that the plan won't go off the rails. These are the people who are the problem solvers, not the problem generators. They're not going to wilt or throw in the towel at the first issue, and they're going to adapt, and they're going to find that modality to make this a successful solution, not collapse immediately under the weight of any pressure. So what you want to be doing is, your guiding principles for going to scale is you want to start with the why. Why are we doing this project? And your reasoning could be many. It could be outside competition, that they're getting closer. It could be a large surgical backlog and you have many patients waiting and you want to find a way to get more patients through in a quicker manner. There could be a new practice guidelines that are out that identify that one pathway is safer than another pathway. If you lead with the why, what you'll find is that it is easier to get people on board. What you're trying to do them is pull them along of, here's the why, come follow me in order to how to get there. If you just are starting with the what, and even worse with the what and the how, that tends to be pushing them. And you know what happens when you start pushing people, they're instantly going to push back. So if you start with that why, if you start with the message, if you start with the theme, you're going to be able to pull them in and have them pull them along. Those local champions who are your rock stars, who are your superstars, who you know are going to try really hard and really do whatever the problem solving is to make that work, are going to be your key champions. And it's not just going to be in the anesthesia department. You're going to need it in all of the different areas where you're working. In a total joint program where one thinks that it's just the surgeons and anesthesia, you don't. You need the circulating nurse, you need the scrub tech, you need the PA, you need the pre-op nurses who are going to get the patient ready and help support the system. You're going to need the recovery room nurses in order to do all the different steps of making sure that the patient is hydrated, the block is wearing off, that they're going to call anesthesia for support. And notice that I'm slowly moving further and further out. You're going to need physical therapy. You're going to need your pre-op nurses and surgery schedulers and your surgery educators to make sure that the patient is ready on day of. You need your solid perioperative medicine division or whomever is preparing your patients physically for their procedure to be on board also. You're going to need your home PT. You're going to need your DME set up also. So whereas if you think that this is just a simple operation and just a small circle, it in fact goes out further and further. Where you can, for the what and the how, having a playbook of either what has been successful or what has been shown to be successful at the pilot sites can be helpful, but understand that playbook may ultimately turn out to be more of a guideline. Ultimately, what you want to do is have these patients follow through on a pathway, but there may be some local geographic, structural, or other operational differences at each of the sites that allows them to make it a little bit more unique for themselves, whether that is the proximity of their operating room to their post-op area, how the patients flow through the hospital. And you have to be able to allow for that. Being completely rigid of saying, this is the playbook, it is written in ink and it can't be edited, will be a mistake. You'll want to measure what matters, what type of anesthetic is being used, their door-to-door time, when they get into the hospital to when they get out of the hospital, how long they're staying in the PACU. And all of these things, as you build this culture, will build sustainability, but you want to start it at the rollout. Next slide. So when you're determining site readiness, obviously you've either been trialing this at one area of your super motivators, and you've shown that it could work. You've expanded it now to their regular group, and now it's time to move it out to the larger enterprise. This is not a light switch. You're now going to take all of these principles that you've had before, and you are going to work them at each of these sites as you roll out. We do total joints it's varied over the years, but anywhere from 18 to 21 of our sites. We're not going to start with all of our sites on the same day. Again, we're going to choose a cohort. And so each of those cohorts, we're going to follow through. And we're going to follow through with the same pattern that one would start a pilot. The messaging has been going around the whole time. The messaging to all of the rank and file, to all of the associate groups, and the teaching has been going out for a while so that everybody is aware. This also gives you the advantage of, as you have your higher performers starting on the pilots, that the other people can see how this is happening. They're almost observers of saying, okay, I see this, I see that, I see where they're putting the spinal, I see how the patient's doing in the PACU, and wow, look, they're recovering really quickly. And moving on. And so you're almost maybe not those early adopters, maybe those sort of middle adopters to late adopters can see the successful pattern along the way. And that helps get the buy-in. Additionally, you're hearing the socialization in the lounges, in the hallways, and in regular meetings as you're getting report outs. One of the things that you have to do with those high achievers and your early trial people is they have to appreciate also that they may be able to do this at an exceptionally high level, but not everybody may. They need to be able to troubleshoot, not necessarily so the lowest person, because you're not looking for the bar that's the low. You're not even really looking for the bar that's the middle. You still want it to be a high achieving system, that they have to be able to adapt the techniques and the timing and be realistic about what the majority of the group is able to do. Again, not necessarily on the low end, moving it to the higher end. Give the people an opportunity to see what's happening, to give them an able to shadow and follow through so that they can see firsthand, especially if you're doing a very large change, that it is completely acceptable. And again, going back to the playbook is key, but there will likely be some variation. And we found a lot of these things along the way. So once you have your rollouts, you really need to encourage that feedback as you're getting ready to roll it. You start building your teams out and who's doing it on a regular basis. Maybe you do 3 rooms of total joints one day. You start with 1 on a couple days with the high. You move to 1 day every single day, and then you start adding your separate rooms. And then you want to start looking at your clinical outcomes. As we were starting to look at the data as we were going, we noticed a few trends. We noticed that 90% of our anesthesiologists were doing spinal anesthetic for their total joints, and maybe 10% were doing general anesthetics, except for at one location where it was completely reversed. And we had Dr. Yap's paper, and we used that as an opportunity at an offsite to not directly say to this one group, this is how you need to do it. But again, in that idea of pulling them along, we're like, here's a better way to do it with better outcomes. And did that again and saying, instead of doing that top-down forced, which nobody likes at all. Now, I will say I did have to reach out to the chair of Arthroplasty to advise him that we were doing this at an offsite, and this group was going to show up on Monday morning and completely change the game plan. And he had an opportunity to let the total joint surgeons at that hospital know that this was coming. Another thing that we found is we were doing this and we were becoming so effective at the time of getting patients through on the day that there were some hospitals that weren't able to turn trays around fast enough. And we had to go and source more trays because their SPD wasn't able to keep up with the work. We also identified that some patients, especially the patients that came out between 7 and 11 in the morning, tended to stay in the PACU for a lot longer and bogging things down than the patients who were coming out in the afternoon. And so we went back and we looked, and we had the anesthesiologist doing a little bit more patrol in the PACU. We had encouraging the nurses to call early if the spinal wasn't wearing off, if the patient was hypotensive, if there was nausea, so we could intervene and we could cut into these processes earlier. Instead of waiting and just playing passive and ultimately having sabotage. And we also realized that that we needed more resources in certain areas. Your physical therapy, if you're going to be testing these patients before they go home, have to be aligned in their schedules so that they're available as these patients are coming out. So you need to give them a heads up so they can finish up their other assessments to make sure that they're available. And it's all of these little steps that you perhaps didn't find out at the pilot site because it was either so well tuned in or so well resourced that as you go out to your other sites, you have to make some adjustments. Next slide. So I make this sound like it was so great and all these problems came up, but there's always problems. You're going to have some places, as we talked about, we have sort of the general service lines, but then we have local control also. And you have to make sure that the priorities are aligned at those locations also. If they are under-resourced or underutilized, or if they're under-resourced or overutilized, and this pilot program is not going to be, is not of a priority to them, you're going to have some trouble getting stickiness on that. Communication gaps, as I talked about with the recovery room nurses. There's also that idea of, you give this idea and people will just instantly say, yeah, I'm not doing that, no matter what you do. And that's where early socialization and early conversations can happen. There will always be the naysayers, the what's in it for me, I don't want to do this, it's too much work. Some of it is just overall wearing them down. You are always going to have a late group of people who just don't want to get on board. And you have to use not necessarily the peer pressure, but really, look, everybody else is on the bandwagon. What is the resistance that you're having? And if you don't have sustainment planning of where you're ultimately able to turn this into, we're really motivated and we're really excited to do it, to this is just how we do it. This is just a normal day for us, where you take something that may have been a little bit out there, a little bit more than what people would have expected, a bit more of a change than they would have had, to ultimately to just establishing a new normal. So balance in your standardization, having some acceptance for some local site variations as your hospitals maybe and your staff may be resourced differently. Having central government and measurement so that you're looking at the data points will enable the durability of your project. Again, accept in your rollout that there's going to be some diversity along the way, but as long as you're getting everybody to the finish line, going back all the way to program launch to think about the sustainability and to demand that sustainability in the project. And really, I have to say, one of the most important things is really leaning on the why and getting the buy-in of people so that you're pulling them along versus setting up barriers for them to want to push back to. Thank you. And I'll turn it over now to Dr. Nornberg.
Thanks so much to Dr. Toma and Dr. Cohen and Dr. Yap. My gosh, I feel like in the room with giants. It's just so cool. But let me get my slides up here so that way you can see. 1 second. And we're going to play that. Okay. So I'm going to kind of pull back a little bit from the amazing presentations that we've had from our NCAL, our Northern California
Jennifer,
colleagues.
you're in presenter view. Sorry to interrupt.
Oh, sweeps. I will switch. There we go. Thank you so much. That's better?
Yes, yes.
Okay, thank you for correcting me. It's hard to tell because of the way that the screen looks. Anyway, so back to talking about what we do down in San Diego. So I am a physician also with Kaiser Permanente, but the way that our systems work in Southern California, we are a different physician group than my colleagues up in Northern California, and our organization is quite a bit different than the way that they have established the perioperative division. And it's something that's very inspiring and something that we are working hard to adapt into our own um, regional setup where we have Los Angeles and San Diego as our two principal areas. Los Angeles is broken up into a lot of different sites, kind of like how Dr. Toma was talking about the diversity of the different sites. So what I'm going to do is I'm going to present a little bit of information looking at the patient as a stakeholder and how important it is to make sure that we are looking at their outcomes as well as we are developing that program to make sure that they are optimized and risk stratified. So my objectives here are to look at the patient population that are undergoing lower extremity total joints down where we are, and then talk a little bit about the generalities of the comorbidity and frailty that goes along with being a total joint patient of that age group. And then we'll look at some of the studies that have examined patient education programs, prehabilitation, which I will define for us a little bit more, and then also expectations for how to recover from the surgery afterwards, and then look a little bit at what we're doing down in San Diego. So no financial disclosures, as we mentioned really early on. So frailty and comorbidity, just as a value in the United States alone, we're estimating that we'll be doing annually 635,000 total hip arthroplasties and 1.3 million total knee arthroplasties in the year 2030. So that's, again, annually, that's a huge number for our country because of our aging population. And 70% of that aging population have at least two chronic conditions or geriatric syndromes. So when Dr. Cohen was talking about the importance of optimizing the patients and having a system in place, his system that they developed is the CAST score, which is using automation within our Health Connect, which is an Epic-based EMR. And there are other scores that you can use. These are listed here: the Clinical Frailty Scale, the Charleston Comorbidity Index, the Alex Hauser Comorbidity Index, so on and so forth. Each one of those studied and listed in that reference down there below, talk about their pros and cons about using that to predict the probability of the patient needing to have things like mortality risk, both in the hospital and out of the hospital, how long they going to need to be in the hospital, and then what kind of cost impact it will have on the medical system as a whole. This paper here that's listed has also some really great rehabilitation thought processes. So patients then they're coming in for a total hip or a total knee, they have mobility issues. So they're limited in their activity. So how can we optimize that for them? Is it going to be things like weight loss? Is it going to be aqua therapy? Can it be other weight-bearing exercises, resistance training? Can it be other things that get them mentally in a better place to make sure that they have the wherewithal to be prepared for getting ready for the surgery, making sure they have all of the resources they need to be able to recover at home on the same day, as Dr. Yap was talking about with the anesthetic techniques. And then how else can we look at educating the patients and family? Are there different systems that we can use in order to effectively and efficiently distribute the information and make sure that the patients are digesting that information? So rehabilitation studies, there's quite a few of them. There's quite a few meta-analysis out there. They look mostly at 48-week programs that include resistance and aerobic training. They look at educating patients about the nature of the surgery, the nature of the body and basic anatomy, and then also the why behind the exercise need and the resistance training to help optimize their outcomes. And then they did outcomes measuring of things like range of motion, how functional they are, how much mobility they have, how much quality of life they have. And then that predicts things like intraoperative or postoperative complications, length of stay, whether they're going to be a same-day patient or they're going to need to have additional resources afterwards. And these studies tend to be small and protocols tend to be varied. So trying to compare apples to oranges can be really difficult with these studies. And so one of the things that we're working on down in Southern California, at least for our region, is to have a partnership with the Center of Healthy Living to be able to standardize our process so that we can study it and potentially scale it, as Dr. Toma was talking about. So postoperative recovery expectations as part of that program, the important things to think about in that sense are looking at pain perception. Getting your joint replaced is painful, and making sure that the patients have the way to understand how to manage their pain with the medications, multimodals, as Dr. Yap mentioned. That does lead to higher satisfaction and higher functional status at 3 months, because the head game is just as important as the physical game. The day of surgery is just one day. If we can work around making sure these patients are ready preoperatively and postoperatively to be able to be their best around that chapter of surgery, that perioperative journey, then we are going to reduce cost. We're going to make sure that we are improving how they are functioning and then improving their quality of life. But again, the studies are small, and what is the most efficient and effective and cost efficient as well way to make sure that we are getting them the opportunity to digest the information, and their families and care team to be able to digest that as well. So just a little bit more information. This is San Diego. San Diego has a pretty high volume. We did just over 2,600 cases between primary, so not revisions, this past year. And this is just San Diego alone. This is not any of the LA basin at all. And 85.8% of our knees went home. It was a little bit lower. It was about 72% for our hips. I don't have our comorbidity scores. Wasn't able to get quite as much wonderful research background as Dr. Yap has up in Northern California, but hopefully we'll be able to do some more data mining for that. But one of the things to notice is we had a nursing strike that started in January. So our numbers kind of stopped at the beginning of 2026, and we're picking up again. So pay attention to just the left-hand side of that graph, where we did do quite a few cases and had a very high efficiency. We have a program that we currently have about a 6-month waiting period for the patients from when they get scheduled to surgery and when they actually get their surgery day. Plenty of time to educate them. We have 3 nurse managers that work with the orthopedic department to coordinate getting these patients optimized. They have to complete an education program that's a video class as well as a PDF packet. And then if the surgeon feels that the patient needs further optimization, they set up an anesthesia telephone visit. We have a lot of work to do to make this more automated, make that more objective, and make sure that we are reaching all of the patients that do need additional optimization. But that is part of the scaling that we are working on, and that was so lovely to hear from Dr. Toma. This is just our table of contents of that PDF that I was referring to. It does highlight in a lot of table format and almost like a workbook, where they can have the timeline leading up to their surgery and making sure that they have all of their boxes checked, basically. And so it's about a 22-page document that they have to work through, that goes through how to bathe, how to prep, get their home ready, get your family members ready, get your health comorbidities in line. All of that kind of information is all listed in that packet. And we are also embarking on additional partnership, as I mentioned, with our Center for Healthy Living program. We call it Positive Choice down in San Diego. And it is principally around nutrition and weight loss, but they have resources that are easily adapted into the perioperative space. So we will be working with them to develop additional video worksheets and other types of visits to give them an opportunity to further optimize not only their medical problems, things like diabetes, hypertension, cardiac health, but also to optimize their weight, optimize their nutrition so that we can reduce both same-day cancellations by making sure that they're following the diet protocols, and then also making sure that we are reducing things like postoperative infections because they have better wound healing. We'll follow these outcomes for things like length of stay, functional status, SSI risk, and also looking at cancellations, and aim to reduce our backlog because we will have better stratification of where these patients will be scheduled. So that is what I have. The references that I had in the talk itself can be found on this QR code. It will link to a Google document that has all of the links to those PDFs. So if you would like that, you may scan that. And you may also reach out to me on social media if you have any other questions. If we have run out of time, I am more than happy to connect with those wonderful people that we've had in the talk today. So I think at this point I am done, and let's open it up to questions.
Thanks, Dr. Nuremberg. Have all the panelists hop back on. We have a few questions in the Q&A, and I'll just start with Brad, Dr. Cohn, if you're there. If not, okay, great. So for centers that have low resources, health centers that may not have all the resources that Kaiser has, how would you garner support for an optimization clinic or a pre-op clinic? And then a follow-up question to that is, you presented some great risk stratification scores that are deployed in the EHR, but how about if you don't have that infrastructure? How should one develop that triage system?
Yeah, thanks, Ed. These are great questions. I'll take the first one about differently resourced settings. I think as opposed to thinking about well-resourced or poorly resourced systems, I think about integrated versus disintegrated systems as the real differentiator here. There can be integrated health systems in low-resource settings that do this quite well. And I think this has to do with the fact that integrated systems, whether they're national or some smaller form of governmental systems, often have the interest of the patient's health, whether it be perioperative or outside of the perioperative setting, in mind, and have structures to coordinate the efforts of family medicine or primary care providers with the surgical care teams. I think that is really the differentiator. If you can link what happens in the periop space with what's done to keep your population healthy at baseline, that's the underpinnings of a successful perioperative medicine program, and it doesn't require tremendous additional resources. To the second half of your program, I would say something that is highly effective but not very costly is building consensus around your clinical care teams about what optimized is and what optimized is not. Technology, an integrated health system, makes it easier for you to sort your population into optimized and not optimized status, but the foundation is agreeing what that means. Because if you don't have agreement among all your clinicians about what a patient looks like when they're ready and when they're optimized, you have the same outcomes of different rates of cancellation, different approaches to intraoperative care, and a heterogeneous approach to care is one where I see a lot of opportunity for improvement. I think it's a great question. Thanks.
Thanks, Dr. Cohn. I have a question for Dr. Toma here. Again, for low resource systems or systems with fragmentation, how can an anesthesia department capture ROI or return on investment for all the work that they do, and some of the strategy of looping back that ROI to support anesthesia resources?
Sure. I think, first of all, you have to look at, is it a matter of taking something out of the system or putting something into the system? And, in the case of creating a streamlined pattern for total joints, building on what Brad said, it really is no different of if you're able to get those patients, as Dr. Cohn talks about, getting the patients properly through the pre-operative period so that they have a successful time in the intraoperative period. There's no difference in making that investment in the intraoperative period in order to set them up for success in the postoperative period. if you are, our pathways have been very successful in showing that patients can go home without readmissions. So that's saving the patient a night in the hospital and getting them home in a more timely fashion. Additionally, sometimes it's small investments that allow that to happen. Most of our total joints historically were always done in the hospital. So if you look at resources like nursing, pharmacy, physical therapy, those were all part of the system. But if we move it to the outpatient arena, you may not necessarily have physical therapy co-located in that ASC. But by making that investment of having the physical therapists out there to do those assessments, at about the time when patients would come, you don't need them there for the whole day. Again, you now have shown success for the system. If this also improves your throughput through the day so that you can add 1 to 3 more cases during the day, now you get the return on investment for not only for the extra costs of the surgery, which is way better than just sitting around with idle time. So sometimes you actually have to put a little bit of money in order to get more money out.
Thanks, Dr. Toma. That was a great answer to that question. The next question I have is for Dr. Nordenberg. I really appreciate the prehabilitation presentation that you had in your slides. It seems very potentially resource intensive. How can we get buy-in for a program like that? How can a hospital system initiate a program? Any comments on that?
Sure. Actually, it's surprisingly not that resource intensive. So there is some setup cost and setup time, but for the most part, because most of these interventions are done as a single education point to the patients, and then potentially giving some follow-up. There was a Canadian study that did an 8-week program in which they gave the patients a exercise program and then checked in every other week. It cost about $120 per patient. That is including the materials and then the check-ins. And they showed the length of stay reduction was statistically significant. And so I think there are a lot of materials out there already as far as programs go, PTs go, we're being able to work with a physical therapist to optimize little tweaks to that. But overall, once you have the initiation, getting the actual deployment shouldn't be that expensive. So once you start seeing, just like Dr. Toma was talking about, sometimes you do a little investment at the beginning, and then you start seeing the reduction in the length of stay. You start seeing reduction in the complication rates because these patients are better prepared. And then you see more satisfaction, so more retention of members, then the investment is very, very worth it. So low risk and relatively low cost.
Thanks, Dr. Nuremberg. There are a few questions in the Q&A as well. I'll just open it up here for Dr. Toma and Dr. Cohn. Is the parameters for same-day discharge on this, is it the same day as surgery, or is it discharge within 24 hours? Is it different for knees and hips? Any comments on that?
It's the goal is same day. We used to have 3 categories. It was same day, sunrise, and admit. And so admit would be, so sunrise was, I'm not going to say they were out by the first case in the morning, or the discharge orders were written before the surgical team went to the OR, but I think it was 9 or 10 o'clock in the morning. The patient was out the next morning. And for some, it was usually the last case of the day. Whether it was a spinal type issue, or the spinal not wearing off, or some other reason, was usually the reason for keeping them overnight. There was also, as I was talking about, when you go back and you look at why are patients staying, and is it that their orthostatics were lasting too long and we didn't replete them with fluid? Were they nauseous and we didn't pre-treat well enough with antiemetics? And essentially doing the homework to find out what those causes were, and then targeting those causes specifically.
And I would just to agree with Dr. Toma. I think we can all recognize that the greatest value comes from a patient who's safe and ready to be discharged from the post-anesthesia care unit. That allows not just for the patients to have the greatest benefit of recovery at home, but allows you to provide that care outside of a main hospital setting, in an ambulatory surgical setting, where increasingly we're seeing the volume of care moving to those types of environments.
Thanks, Dr. Cohn, Dr. Toma. I believe that those are all the questions that we have. I wanted to thank my panelists here, Dr. Norenberg, Dr. Toma, and Dr. Cohn, for joining me on presenting all this information. I hope it was a great presentation for you guys listening. And thank you for the IARS team, Tracy, Kristen, and Andrea, for being here as well. This lecture will be recorded and available for other viewing. So thanks so much for your time and attention.